Hi, I'm Benjamin Valbaum. I'm a medical oncologist from Chile. I work at Hospital Pontificia Universidad Católica in Santiago and have been enjoying San Antonio Symposium this year. I'll be discussing the data regarding hormone receptor positive early disease, and probably the most interesting data so far was presented yesterday by Dr. Aditya Bardia from UCLA regarding the Leida trial. So the Leida trial is a trial that shows or compares the use of an oral SERD, giredestrant versus tamoxifen or aromatase inhibitors in the early stage for intermediate and high-risk patients. So it randomized around 4,000 patients, 2,000 per arm, to either giredestrant plus ovarian function suppression in premenopausal patients or aromatase inhibitors or tamoxifen. It included mainly, or around 70% of patients were high-risk disease, and around 40% of patients were premenopausal patients. Around 80% of patients did receive prior chemotherapy, so that reinforces the high-risk patients that were selected. And what it showed, or the main results, are that the use of at least for 5 years of giredestrant reduced the risk of recurrence or invasive recurrence in around 2.8% and distant recurrence in around 2.1%. So if we put this into context with other trials such as the CDK4/6 inhibitors as ribociclib and abemaciclib, at this same time point, that's around 3 years, the benefit that this new drugs showed was pretty similar, 2.8, 2.5% as well. So it's very compelling to analyze this data and to see the longer follow-up, if this will impact survival differences or overall survival in the future. But if we think about it, it's the first trial that shows a benefit in the last 20 years of new endocrine therapies in the adjuvant setting. The problem is it has still, or brings a lot of questions on how to combine this new therapy with what we have so far. So in the past 2 years or 3 years, we've been listening to the growing data regarding abemaciclib and ribociclib as adjuvant therapy for high-risk and intermediate-risk patients. But in this trial, these patients were not included, so it was not permitted for patients to receive CDK4/6 inhibitors. So we don't know how we're going to combine, how we're going to sequence these therapies as well. And the other question that's very important is regarding toxicity. So it was kind of disappointing to see that there were no big differences regarding toxicity with an oral SERD compared to standard of care therapy. We were expecting maybe, or I was expecting maybe a bit that patients tolerate a bit better this treatment. It did show less discontinuation rate, but well, this was an open label trial, so probably that could explain this difference as well. We're waiting for the data of the premier trial that will show if these oral SERDs do need ovarian function suppression in premenopausal patients, so this could help us or maybe see this therapy without ovarian function suppression is better tolerated. And the other question that's very important, it's regarding cost. I come from Latin America, so you can imagine that spending $25,000, that's a reference price for other SERDs in the metastatic setting monthly, just to avoid 2.8% of recurrence seems kind of disproportionate so far, but well, we've got to see the data as it moves on. And how can we select better patients in the future to determine when to escalate or de-escalate in the adjuvant therapy? Well, there were 2 trials also presented in the past 24 hours regarding the use of ctDNA in this setting. So the first one was presented yesterday by Heather Parsons on the PALACE trial that showed that ctDNA baseline after local regional therapy and adjuvant therapy with chemotherapy was prognostic. This is not new, we already knew that. But what it did show is that when we see a decrease in ctDNA, we do have better prognosis. The problem is it did not show that palbociclib increased the clearance of circulating DNA. Today, in the morning, we saw the Leida trial. It's another phase 2 trial, pretty similar to what we presented before, but this was with ribociclib, a smaller trial, and it did show, very interestingly, though in few patients, that ribociclib could increase the clearance of ctDNA. So this is kind of a sign, a signal. Probably we still need a bit more data on this. The sensitivity of this test are probably not perfect yet because the majority of patients that do recur still have ctDNA negative at baseline. So there's still many things to learn. So again, probably this data is still immature. We still need time to determine when to use one or the other, if we're going to be able to use oral SERDs plus CDK4/6 inhibitors and what this means for the health system, for instance. But again, it was very interesting, and I hope that we see survival differences in the future. Thank you very much.